Hello, everybody. It is a privilege to be among you once again. So, I'm here to brief about what primary palliative care looks like in the Asian region. So, I would start off with giving you an overview of the Asian region, the status of primary healthcare and palliative care, our special interest group's aspiration to map primary palliative care in our region, finishing off with an example of a successful model. The Asian region is home to almost 60% of the global population and constitutes the Southeast Asian region and the countries of the Western Pacific. This map illustrates how different countries in the world have achieved levels of their palliative care development, with more darker shades representing uh, higher levels of palliative care development. And if you focus on Asia, there are countries from no known palliative care activity to countries who have actually integrated palliative care into their health system in an advanced manner. Special interest group on primary palliative care of the Asia Pacific Hospice Palliative Care Network has a plan moving forward as to what we want to achieve in the region. A team led by Dr. Teguh Perdamaian from Indonesia is conducting a survey where we aim to understand what primary palliative care looks like in the Asian region. So we aim to identify the primary healthcare models, the current practices and initiatives for primary palliative care development, and the population needs. Observations arising from the World Health Organization and other researchers come up with how primary healthcare functions within the Asian region. Moving forward through this survey, we aim to understand where palliative care sits within the primary healthcare frameworks. Here we are learning from our colleagues, and our vision is quite aligned with what Dr. Afalabi and colleagues did in Africa, where they mapped the existing model of primary palliative care, which is shown on the left here, and then the model that they aspire to develop in the region. So the second model that they envision is quite integrated with the communities, homes, non-governmental organizations, and secondary and tertiary levels of care. Now we move on to exploring a successful model on primary palliative care from within the Asian region, India. So India is a Southeast Asian country with a population over 1.4 billion and a three-tiered health system, primary, secondary through tertiary levels of healthcare. In terms of palliative care development, it is between 3A to 3B. Why I say so is in certain areas where there is a successful model being implemented, there is generalized provision of palliative care, whereas in some regions, palliative care is not as much developed. We are to look at a country level model, but here we start with a model that an individual organization came up with in the early 1990s. So the Calicut organization of Kerala, as published by Dr. Rajagopal and Dr. Suresh Kumar in this image, they have kept the patient right at the top of their model, followed by the supporting family members and the community volunteers, which is something that not all the palliative care models have this element of volunteers. So we are going to discuss more about that later. And then all these three elements are supported by the government hospital and the non-governmental organization, the Pain and Palliative Care Society. Within this model, the community volunteers form a unique element who support with establishing palliative care units, home visits, running outpatient clinics, administrative work, raising funds to function these units, and mobilizing support for the patients from governmental and non-governmental organizations. Because of the involvement of community volunteers, these palliative care units render beyond clinical services. food for the starving families, education for the children, transport facilities for the patients to get abroad from the primary care centers to the tertiary care center, and so on, and equipping family members for income generating activities, financial support in emergency situations for the poorest of families. And community volunteers are sometimes trained to provide psychosocial support for the patients and families. And they also form a link between the patients and the local social or religious organizations, and then also non-governmental schemes. It was important to note that right from the inception, this model was functioning on several important principles. The patient's needs should come first, not the organizational motives. If it does, people end up building monuments, helping a handful of patients and becoming gods to keep the others out. Secondly, the average villager is quite capable of making brave and intelligent decisions regarding treatment options, so not to confuse between the patient's level of literacy and their intelligence. Volunteers, as you would have seen, form the backbone of palliative care delivery in the society. Fourthly, religious and social convictions of carers or organizations should never be imposed on the patients. They have stressed on the importance of building awareness among the public about palliative care and the services rendered for them to reach out whenever in need. Then, about the fair distribution of resources, quoting them, expensive equipment or drugs, such as sustained release formulations, are justifiable only if their use does not subtract from the services available to the very poor. And finally, to coexist with the alternative systems of medicine, such as Ayurveda, because people tend to um, uh, receive care from these alternative sources of medicine as well. So, very importantly, in 2018, the Indian Association of Palliative Care and the Academy of Family Physicians of India came up with a joint position statement to foster policy, education, and service delivery considerations. I think it is very important to note that they have really touched all four aspects of palliative care development through this joint position statement. Here is the currently working model on palliative care in India. So it has three levels. I put the pyramid there to show how the community level functions at a massive scale at the foundation, and the specialist palliative care centers or individuals right at the top of the pyramid. And the primary palliative care forms the middle layer that provides care while also forming a link between the specialist and community services. So the primary palliative care team, which may also do home visits, community visits, have a core team, general practitioners, community nurses, and social workers. And depending on the context, there could be other professionals and individuals involved in an extended team. So it was very important that they understood what challenges they faced and what were the facilitators as they implemented this model through audit and research. So it is very important to learn all that moving forward. In recent publications, it was stressed that the Indian model functions on five core aspects of a successful model. So that is good interpersonal communication, knowledge and skill enhancement, clearly defined roles and responsibilities, especially between the specialist care teams and the primary care teams, a streamlined referral and back referral system between the specialists and general practitioners, and assurance for a continuous and coordinated support for the patients, families, and carers. Forward, they are developing a web-based application for the primary care physicians or clinicians to access information about palliative care management, and also do an online form of training for these physicians. Thank you.